want to thank everybody for joining our latest journal club. Really delighted that Darcy Reisman had some time to discuss many of the various different areas of her work. One of them being is the concept of high intensity and walking and ambulation. Dr. Reisman is the chair of physical therapy in Delaware, but I mean, she's really, to me, one of our top leaders in rehabilitation medicine and stroke. So I'm really delighted that she had some time to speak. So please, Darcy, take it away.
Yeah. So for those of you who were on when Dr. Savitz and I were just talking, I have slides prepared, but I really, Journal Club is meant to be interactive, not me talking. So I really welcome folks to just unmute yourself. And if that's okay with you, Dr. Savitz, just have people unmute themselves and ask a question. Is that okay?
Sounds great. Absolutely.
Okay. That way I can't, because it's hard for me I can't see all of you. So if you raise your hand, I might miss you. So just unmute yourself. I'm going to be talking today about, or discussing with you, I hope it's not just me talking, discussing with you today our paper on improving walking activity in those with chronic stroke. This was the primary results from what we call the ProWalks trial, which was promoting recovery optimization with walking exercise after stroke. And so the next slide is just disclosures. And then I want to jump right into a little bit of the background for this work and sort of this is a little bit more than what's in the paper. But I think it's really important to sort of set the stage for why we were interested in doing this. So as probably most of the people on this call know, stroke after stroke, a lot of participants or a lot of people have difficulty moving. And that difficulty moving really results in less activity or sedentary behavior. And that reduction in activity puts them at greater risk for a whole host of other medical problems, not the least of which is second stroke, but also heart failure, heart attack, diabetes, and of course, most significantly at risk of death. And it really becomes potentially this very vicious cycle that one of the goals of rehab, of course, is to improve people's functionality, but also to break this vicious health cycle. And when we really, we're thinking about this problem of reduced ability to move and therefore less activity, we really approach the problem from the framework of the World Health Organization ICF model. And the ICF model. Oh, I think somebody might want to mute. Yep. Let's see. There we go. All right, great. So the WHO ICF model, of course, has health condition, at the beginning of the model, which in our case would be stroke, and it really features the effect of that health condition on body function and structure, activity and participation, and of course looks at the influence of environmental factors and personal factors. And for the main primary outcome of this paper, we were really interested in this activity domain of the intervention, of the WHO ICF model. So if we really take a look at that activity domain in more detail, the World Health Organization breaks that activity domain up into two qualifiers. One is the qualifier of capacity, and the other is the qualifier of performance. So in the activity domain, we can think about capacity, which is what someone's capable of doing as assessed in a standardized environment, like we would do in a clinic or in a lab. So this would be doing things like, measuring walking speed on the 10-meter walk test or measuring walking distance on the 6-minute walk test. The other aspect of activity that we need to think about, however, is, and I think we don't necessarily think about as much as we should in rehab, is performance. And this is really trying to understand the activity that a person actually does in their everyday unstructured environment. And one of the main ways that we look at this when we're thinking about locomotion is looking at steps per day. So I'll pause there for a minute just to see if anybody has any questions about this. This is sort of the framework that we're heading into the study under. Anybody, any questions about that? All right. I talk about this a lot, so hopefully, people are tired of hearing me talk about it by now, but I never want to assume that that people are familiar with that framework. One of the things that's really important about thinking about walking after stroke in this framework is that most of the work that's been done in the literature is really focused on this capacity piece, right? On walking speed and walking distance after stroke. And we know that this can be improved through moderate to high intensity walking training in people with chronic stroke. And right now, Dr. Savitz had mentioned some work that I'm doing with Pierce Boyne and Sandy Billinger on a clinical trial for comparing high intensity interval training to moderate aerobic activity, walking training in people with stroke. And I'm happy to talk more about that if people are interested. To really tease out, we know that moderate to high intensity really can improve walking capacity, but now we're really trying to tease out what are the benefits of true high intensity above and beyond moderate intensity. All right, so I think there we go. Okay. And while the studies have shown these improvements in capacity, when the studies have measured improvements, concomitant improvements in walking performance as measured by steps per day, really those improvements are either modest or pretty non-existent. And in cross-sectional studies, we know that walking capacity only counts for about 30% of the variance in daily walking activity after daily walking activity in chronic stroke, people living with chronic stroke. So there's this sort of feeling that we began to develop, gosh, now it's been 10 years ago, or a little bit more since we started really thinking about developing the ProWalk study, is that, increasing someone's capacity may not be enough to really increase their walking performance or their everyday activity. And, as a therapist, when I started to do some of this preliminary work, that's kind of devastating, right? To do all this work and see these nice changes in our clinical measures and then measure people in their everyday environment and realize, wow, you haven't really moved the needle much on what they're doing at home. And, really our goal is really to change their behavior outside of the clinic. So I really became kind of passionate about this idea of how can we really improve walking performance in people with chronic stroke? It's not enough just to improve their capacity. We also want to improve their performance. And so started to really look at the literature. There wasn't literature on this in people with stroke when we started ProWalk, or started thinking about ProWalks and doing the preliminary studies. But looking in other populations, we know that step activity monitoring programs that track walking activity with an accelerometer and include goal setting related to steps per day can improve walking activity in lots of different populations. And so we really, and we know, our work about moderate to high intensity walking training and its ability to improve capacity. So we said, well, what if we combine this high intensity walking with these step activity monitoring programs? Could this combination lead to this improvement in performance? And we did a preliminary small feasibility and preliminary efficacy study that showed some really nice results with this combined intervention. And so we then received funding from the NIH to launch into our multi-site clinical trial that I'm now going to talk about. Does anybody have any questions so far? Okay, so you hopefully understand sort of our rationale for doing the study that we're going to talk about today. That's the paper that you hopefully read. So this was a 4-site single-blind phase 2 RCT. These are the different sites that were involved. We enrolled from July 2016 through November 2021. Hopefully you'll notice that the COVID pandemic happened in the middle, which is always an exciting time to be doing an in-person clinical trial in people living with stroke. But nonetheless, we got it done. These are some of the basic inclusion-exclusion criteria and some of our basic measures. I really want to highlight here that we were really trying in this clinical trial to represent the kind of people that walk in our door living with chronic stroke walk in our door in outpatient rehab facilities. So we had a very wide age range. Everybody had to be living with chronic stroke, so greater than 6 months post-stroke. They did have to have the ability to walk without assistance from another person. And we felt that that was really important because we know that walking performance, that is what you do in your real world environment, is really quite different when you require another person with you. And so we wanted to sort of eliminate that variable, which I know does eliminate some of the generalizability of the study. They also had to have walking speeds between 0.3 and 1.0. And the rationale, I think you could appreciate the rationale for the upper end, which is when you start to get into these higher walking speeds, you start to get into a quite high functioning group that is often, really not seeking rehabilitation services. The reason for the lower end is because of some of the accuracy issues with the Fitbit, which was the device that we were going to be using. And so we really had to have that lower walking speed criteria for that reason. And then we were really targeting people who were walking less than 8,000 steps per day, because people walking more than that living with stroke are really getting quite high levels of activity and probably were not the type of person that was in need of this intervention. You can see our exclusion criteria. I think the most important thing for these exclusion criteria where they couldn't currently be in physical therapy, they couldn't really have significant cardiac issues in the last 3 months, and they had to really be able to be able to cognitively intact enough to sign the informed consent and give informed consent and communicate with us. These are our measures. The key measures here, you'll notice our primary outcome highlighted here in red bold was steps per day as measured by the Fitbit, and our 2 measures of walking. So that's our performance measure, and our 2 measures of walking capacity were the 10-meter walk test for walking speed and the 6-minute walk test for walking distance. Let's see, I've got something in the chat. Oh, nope, sorry, that was maybe not meant for me. Ali, I can see your hand. Or Ollie?
Yeah, I'm sorry. You can say it however you want. Just question regarding the inclusion. Is there any? I'm sorry if I missed this, but was there any reason not to include patient less than 6 months post-stroke?
Yeah, very great question. So we were really interested in people living with chronic stroke because that was where the majority of our work at the time had really been done on the moderate to high intensity walking, and sort of from the perspective of the preliminary work, we needed to continue to focus on that group. As you are well aware, there's been a lot of work. I mean, and again, remember that, this study, was planned, gosh, when we conceptualize these ideas, we're talking, more than a decade ago now. And, since then there's been a lot of work in that space in subacute stroke. So I think, there could easily be a study now in people living in sort of in that, post-acute phase, sort of subacute phase. But at the time, we just didn't have the data to really support that. Does that answer your question?
Absolutely. Thank you very much.
Yeah.
Darcy, I also wondered, I guess the fact that you're past 6 months also means you have more patients eligible because many of them won't be getting physical therapy. I wonder if you might comment on that as an issue too, thinking about therapy services for people beyond 6 months.
Yeah. So there was another, so there's, besides the answer that I just gave Ali about the high intensity part, there was another sort of theoretical piece to this for the step activity monitoring piece. What we're really trying to aim to do is to change people's sort of everyday walking behavior so that we would break the cycle of sort of the revolving door of therapy. And I'm sure many of you can appreciate, right? People, once they get past that subacute phase, they're not getting regular therapy. Many of them are going home and being very inactive, which then results in a decline in their mobility. They go see their physician. Their physician recommends, maybe they're starting to fall. Maybe their family members are, concerned. Maybe they themselves are concerned about their lack of mobility. They go to physical therapy. by our measures, our capacity measures, they're getting better. But then we know when we measure what they're doing at home that they're not really translating that improvement into their everyday activity. And we haven't really then broken that vicious cycle. And so that was another reason to really focus on those people living with chronic stroke, really trying to make a change in their everyday behavior, sort of those everyday patterns that they've settled into once that intensive rehab phase, inpatient, outpatient rehab phase is over. I see another hand up, but I can't see the name of the person.
Oh, it's Dr. El Nahas. She's from a wonderful colleague from Egypt.
Okay, wonderful.
Hi, everybody. My question is about the wide range of age, starting from 21 to 85. I think this might be, you might have many outliers because 21 has a different basal line of activity and capability for recovery than the 85.
Yeah. So we were trying to make this wherever we could as generalizable as we could to sort of the people seeking outpatient services, which is the reason for the wide range of ages. You will see when we get to the result, or in the paper, you can see that we certainly, the majority of our folks did really have, they really were in that more of that standard middle age to older adult range that you would sort of expect. And we did include age as a covariate in all of our analyses because of the wide range, and it was not significant. Does that answer your question?
Yes, thank you.
You bet. Any other questions about inclusion, exclusion before I move on? And again, please feel free to unmute, because if you're not on the first page of icons, I can't see your hand up. Okay. All right. So next, let's talk a little bit about this is a very busy slide, but this is the general design of the study. So our first step was to screen participants, and we screened almost 2,400 patients. Then after they were screened, they entered into the pre-intervention testing phase, which included a physical therapy exam with lots of clinical measures, the cardiopulmonary exercise stress test, as well as a baseline steps per day measurement where they wore the Fitbit device. They were not allowed to see the number of steps that they were taking, and we had folks wear the device for 7 to 10 days, and they needed a minimum of 3 days of good data, and we had criteria for what was a allowable day for their data to be included. Once they got through that phase, and in that phase, of course, is where we were determining whether they met the criteria for walking speed, whether they met the criteria for steps per day, that is, whether they were under the 8,000 steps per day, and also they had to pass the graded exercise stress test, which was really used to set the training intensity, but also to evaluate any unknown cardiac conditions. Once they got through all of that, they were randomized. We randomized 250 folks into 3 groups. All of the groups got 12 weeks of training with 2 to 3 visits a week. The goal was 12 weeks of training. In the FAST group, we randomized 89 people. And in that group, they got the high intensity treadmill and overground walking training. And our criteria for high intensity training was we tried to have them walking at 70% of their heart rate, up at least 70 to 85% of their heart rate reserve. That was set based on information from the graded exercise test. Then in the SAM, or the step activity monitoring group, this had 81 people, and they participated in a daily step activity behavioral monitoring program. And that program included wearing a Fitbit and monitoring their daily steps. And in this phase of the study, the Fitbit was set so they were allowed to see their steps either on the device or in the app that we helped set up for them. And then we also did goal setting with them and we used motivational interviewing type techniques for the behavioral intervention. And I can talk about that in more detail. There is some detail in that in the paper that you all read, but there's often a lot of questions from therapists about exactly how that was implemented. So I'm happy to, as soon as I'm done talking about this slide, I'm happy to pause and talk about that. And then the last group was the true experimental group, which was the combined intervention of the FAST plus SAM. And there was 80 folks randomized to that group. And then following the intervention training block, they went through the same post-intervention testing that we did at pre-intervention. And the main tests I'm talking about today are going to be the 6-minute walk test, and the 10-meter walk test, which were our secondary outcomes, and then the steps per day, which was our primary outcome. We measure lots of other clinical tests, and we've got lots of other papers that have come out and are coming out about those results that I can probably talk about at the end a little bit if people are interested. Let me pause here and see if people have questions about the actual training. That was an overview. Oh, critical, before I take a question, I forgot to mention the overground training. And people always, we've done a lot of work on the treadmill part of this, but the overground training, which is essential. Again, same thing. After the treadmill walking, they did the overground training. And the goal of the 10 minutes of overground training was, again, to be in that target heart rate zone of at least 70% of heart rate reserve. But they were also doing functional activities that they had shared with the therapist that were challenging for them. This included walking on uneven terrain, walking and carrying objects, walking, over obstacles, those kind of standard therapy things that we do that our patients with stroke often tell us they have trouble with. The reason that we wanted to have the overground walking training not just be, overground walking back and forth across, our gym, was because since the goal really was to have people walking more in their everyday life, we really wanted to make sure the overground walking training was addressing things that people had shared with the therapist that maybe were barriers to them doing more of that everyday walking. All right, now I'll pause and see if people have more questions about the intervention. All
Darcy,
right.
I guess I had one question for you.
Yeah.
When designing the intervention itself, were you also thinking about next steps in the process of knowing if this actually led to better outcomes? I'm getting to the issue about kind of effectiveness, like going to the real world, and implementation. And so I just wondered, in your thought process behind the design of the intervention, were you already thinking 3 steps ahead?
Yeah. I mean, and you can see that, like I mentioned, in some of our inclusion, exclusion, and we really did try, I mean, obviously I'm a therapist by original training, and we really tried to keep everything that we did to being things that could be done in a clinic that are, we used a standard treadmill. We didn't use fancy equipment that therapists don't have available. I mean, we either, we took people outside when we could, but, we did, if we wanted to do uneven terrain, we did the classic therapist technique of, putting down the mats and putting the sandbag weights under the mats to make the terrain uneven. We did all of the sort of classic things that you would do in a clinic. We did not use any equipment that wouldn't be available. And the other thing that people often ask me was our harness system. And we did not use body weight support. So we just used the harness system for safety to protect against falls during the treadmill training. It was a standard harness with no body weight support. It was a ceiling mounted harness that a lot of clinics have now. And we also did not use a harness. We do have a harness system in our clinic that can go over and that can go over ground, but we don't have that. We didn't have that in the other clinics that we were in the other sites, and that's not that standard yet in the everyday world. So we did not use that harness in overground training. We just used our standard, typical guarding as a therapist would do. We also, Sean, to your point, we also use the Fitbit, which was, to some scientists, this has been fairly controversial, right? That there's some accuracy issues with the Fitbit, but it was the only commercially available device at the time. And I think, to my mind, there's still really is, that had decent enough accuracy that could be used, that the patients could take home. They could access on an app or access directly via the device that would give them feedback, and that was at a price point that was at all reasonable to ever think this could be implemented in the clinic. There's more accurate devices out there, and they're $500 a pop, and they're never going to be available in the clinic. And they use fancy algorithms that are not, that you have to go download the data to get the steps per day out, and they can't provide real-time feedback. And so that was never going to be something that was going to be in the clinic. So I'm really glad you asked that question, that all of those things, those practical things, played into the design of the study. So thank you for asking about that.
Thank you.
All right. Anybody else? All right. So I just want to regroup a little bit here. So for the study, if we go back to capacity and performance, the high intensity walking on the treadmill and over ground, that's what the FAST group got, right? That's a capacity building intervention in our view. The step activity monitoring program, that behavioral intervention, that SAM group, that's a performance targeted intervention in our view. And then of course, the FAST plus SAM is the capacity and performance building intervention. And we really believed that the group that got both the capacity building and the performance targeted intervention would have the greatest increase in steps per day than either intervention alone. So this is the primary efficacy hypothesis that we were testing. Okay. Any questions? All right, so moving on then to our results. So this is just the typical consort diagram that you'll see. Again, as I mentioned, 2,400 people screened, randomized 250 people, and here's the different groups. Here are the people that dropped out or were withdrawn, and the reasons. I should mention we had no serious adverse events related to the study. Which is a great thing. And by the way, that is pretty consistent in the literature at this point. That this kind of moderate to high intensity walking training can be accomplished without serious adverse events.
And Darcy, so meaning
Yeah.
there was not an increase in falls. I mean, that seems to be what everybody keeps telling me, and their concerns about is that we're going to increase that risk.
Nope. And I, what I want to say about that is that this is I'm going to get a little off topic here. So I also really think that we do have to think about falls per step walked. So if I'm a long distance truck driver, my odds of getting in a car accident just by the virtue of the number of miles I drive, just statistically speaking, are higher, right? And so again, I do think that's always something we have to think about, that, the more someone is walking, just statistically speaking, right, the more chance they're going to have for falling, right? Which I do think is why this capacity building piece can be a very, very critical piece to be thinking about for patients. Even though you're going to see, as you know, in our results, we got some really nice results with just the step activity monitoring program, right? But I think, again, when you're really trying to think pragmatically about implementing this as a clinician, I do think you have to look at the patient that's in front of you and look at, their Berg balance score, look at their mini best score, and really be thinking about their risk for fall as well. And that's a little side note. All right. So just in terms of our baseline participant characteristics, in our key outcome measures, and in all of actually the things that we measured, there were no real important differences between the groups. Treatment fidelity is something I want to spend a second on. It's super important in rehab clinical trials. Treatment fidelity is everything, right? It is knowing and having ways to measure, not knowing, you can never really know, right? But having ways to measure whether the groups were getting the intervention as intended and consistently is really, really important in clinical trials. So we had a lot of measures of treatment fidelity in this study. There's some key ones presented here to try to really understand whether the interventions were being delivered as intended across the groups. And so a key general one is, number of sessions attended, and, making sure that was not different across groups. The mean treadmill minutes walked, that was a comparison that was important for the FAST and FAST plus SAM group, and that did not differ. The percentage of treadmill minutes in the target heart range, it was really important. That was the same across groups, and didn't differ. The mean percent heart rate reserve during the treadmill training. Our goal was 70, that they were 70% heart rate reserve. You can see we did not over the average percent heart rate over all the treadmill training minutes over all the sessions. We didn't hit that. And I will tell you that we have some other papers that are coming out that delve more into this, but you can imagine that that's because that there are early on in training, in the first few weeks, there's a lot of people who are not hitting this for very many minutes. They're not hitting that 70% heart rate reserve for all of the minutes that they're walking. We have some participants who never hit that for the full number of minutes that they were walking. And, on average, about, 53% of the minutes of the walking, or half the time, they were really hitting that heart rate reserve that we wanted. I thought it was incredibly important to be very transparent about this. This is not something that's reported in most studies that you'll see. People just tell you what they aimed for, and they don't tell you what they actually did. And so I think this is really important, for you all as clinicians to see that we're aiming for all of those minutes to be greater than 70%. But if you add up all of those minutes over all the sessions, it just doesn't happen, right? And so you can see that the outcomes we got were with this amount of training in this percent heart rate reserve. And you can compare that to what you see with your patient, what you're getting in your clinic. Also really important to make sure that people were actually wearing the Fitbit and that they were actually achieving their goals that they were setting with some kind of regularity for the STEP activity monitoring program. Any questions about treatment fidelity? Oops. I would really, and I've just really been encouraging the rehab field to be super transparent about these we have more fidelity measures that we collected, about super transparent about reporting these things. I think it's really, really critical for clinicians who are trying to implement this to sort of get a gauge of what actually happened in this study, and probably help them figure out what's really reasonable in the clinic. All right, results. So primary outcome, pre-post, we saw very significant changes in steps per day in the SAM and FAST plus SAM group, and non-significant changes in steps per day in the FAST walking alone group. For a little bit of easier view of this, we now have change on the y-axis And you can see here that the average change in steps per day for the FAST group was 406 steps per day. And that's pretty consistent with the literature for moderate to high intensity walking training. Around 500 steps is what most of the studies were getting. You can see that the other two groups got close to triple that change in steps per day by having the step activity monitoring program. There is no MCID, or there's no real value that we can hang our hat on in the literature for what is a meaningful change in steps per day in people with stroke. But we do know that in a very, very large review of more than 15,000 people, that it seems like a change in 1,000 steps per day is really sort of the amount of change that's needed to really reduce all-cause mortality. And that's not specific to stroke, but that's just sort of in the general population. And so if you think, okay, maybe 1,000 steps per day is something meaningful, then the two groups that had the step activity monitoring program exceeded that. All right, so the next result is our secondary outcomes. This is the 6-minute walk test. All of the groups had significant changes in their 6-minute walk test or their walking capacity, including the group that did not get the capacity building intervention, or what we thought of as a capacity building intervention, and that SAM group in purple. Again, if we look at the change scores, it's a little easier to see. Now we have change in 6-minute walk from pre to post on the y-axis. There are measures of minimal detectable change and minimally clinically important difference in the literature that we can kind of use to anchor this a little bit. The MDC and MCID sort of ranges that are out there post-stroke for this measure for a moderate change are between 34 and 50 meters. And so you can see that the two groups that got the capacity building intervention were in that range, and the SAM group was just slightly outside of that range. For the gait speed measure, all groups again significantly improved, even the group that got just the step activity monitoring program. And again, the change scores here now, speed on the y-axis change scores. Again, the MCID that's pretty consistently used in the literature is 0.1 meter per second. And all of the changes exceeded that for all three of the groups. Let me pause there for a minute. These are the primary results. Thoughts or questions about those results? Right. Okay, so for the discussion, if you get, the results seem to suggest, if you get a capacity building intervention alone for locomotion, so that is just the treadmill and overground walking, moderate to high intensity, didn't really see a significant change in our performance measure of steps per day. If you get just a step activity monitoring behavioral intervention that has, tracking your steps, goal setting, working with a therapist to really identify barriers and facilitators, how can I walk more in my everyday environment, helping the patient build self-efficacy for walking in their everyday environment, we got improvements in performance. If you did a combined capacity building intervention and the step activity monitoring intervention, so combining the high intensity walking with the step activity monitoring, you get an improvement in walking performance. If you do the fast training alone, you get an improvement in capacity. If you do the step activity monitoring program, you do get an improvement in capacity. The 6-minute walk results were the meaningfulness of those was not as strong as we would like, but still we saw nice changes in capacity. And then of course the combined intervention had changes in capacity. So sort of the take home message is that, these step activity monitoring programs result in large changes in daily walking activity in people with stroke. And that really, we think, could be important for decreasing the risk of costly and debilitating complications of people living with chronic stroke. Not to mention that, the functional consequences of sort of that vicious cycle of having difficulty with mobility, not moving, and sort of that vicious downward spiral that we often see after stroke. And so we're really at this point suggesting that step activity monitoring programs should really be incorporated into rehab programs that include high intensity walking training in people with chronic stroke, so that you can really target both capacity and performance and really get changes in both, which we think are critical for people living with chronic stroke to meet, to ultimately meet their goals. So these are references, and happy to take any general questions at this point. I can stop sharing. Let's see, how do I stop? There we go.
Yeah, I really like the study, Darcy. I wonder, do we need a study to look at minimal clinically important differences in step activity?
Yeah, I mean, this is a huge issue, I think, with the physical activity literature in people who are living with some sort of walking impairment, right? Is that we've got all those sort of general guidelines out there, but it's really hard to understand what's meaningful in people who, whose walking is not typical. And so, yeah, I think that's really important to understand. Yeah,
because I think about how, I could see studies that are going to need to get done, and validation, and or if you felt like, I don't know if it's necessary or not to compare it against your more gold standard outcomes, whether that's on amount of walking speed, or and really any other outcome that's already accepted from a scientific perspective, or whether we really just care more just clinically what matters to patients.
Yeah, I just really believe that capacity and performance are just two different things, right? I think that, when I think as a therapist, I think about, if someone comes in, and this happens a lot, people are very frustrated with how slow they're walking, right? And it really limits what they're able to do in the community. I mean, capacity building interventions are really important for increasing speed. I would do that over, I wouldn't do a step activity monitoring program if somebody had a goal of increasing their speed, right? But if somebody wanted to increase their speed and be more active in their everyday environment, then it feels like we've got to add on this step activity monitoring program, because there's a lot of face validity to it, right? People are getting better capacity, but they've developed habits of basically inactivity in their home, and they've set up their lives. And I think this happens, when they come home from the hospital, right? They sort of set up their life for whatever their capacity is at that moment. And, just in doing lots and lots of this behavioral monitoring with people and talking to them, like, they're fully capable of walking down their driveway and getting their mail. But, oh no, my wife does that, or my daughter does that, or somebody else does that, right? And so literally just having people start to do these very mundane things again for themselves, right, makes big changes in their sedentary behavior and in their steps per day. And so I think, but they're not naturally doing it. Our study really shows that they need that coaching, they need that monitoring. The other thing that studies are pretty clear on is people living with stroke completely overestimate how much they're doing in a day because it's not easy for them to move. So they think they're doing a lot more than they are. And they get that Fitbit feedback and they're like, oh my gosh, holy cow. I thought I was doing, so much better. So I just think they're two different outcomes. And I think you have to talk to your patient and understand their goals.
Absolutely.
Susan.
Hi, yes, I had a question. So since motivation plays such a big role in staying active,
Yep.
do you think collecting data on like participants' post-stroke emotional state or like their cognition or how they feel their stroke has impacted their lives would provide some more insight?
Absolutely. So we have a paper, gosh, I can't keep track of what's in press or what. Anyway, to your point, Susan, we have shown that self-efficacy for the ABC, essentially, self-efficacy for balance is a major factor that moderates the relationship between someone's capacity and their performance. So if you have low self-efficacy, you're going to do less, regardless of your capacity. So someone's belief in their abilities, specifically for their balance abilities, is really, really critical. We've also shown that in cross-sectional studies that cognition, people with lower cognition also are not as active. Interestingly, in our large cross-sectional studies with 200 to 300 patients, we have not found depression to be sort of a grouping variable that then differentiates people on their step activity behavior. But I think it's because we're using the PHQ-9, which is only designed as a screening tool, and I just maybe don't think is doing a good enough job. We've also started to collect apathy measures because apathy is distinct from depression. And so I think there's a lot of evidence that those things are really important factors. A lot of that work, yeah, just Susan, real quick. Allison Miller is the first author on a lot of that work. Yeah. Go ahead, Elle.
Yes. After the patients finished the duration of the study, did this continue in their daily life, or you didn't follow them?
Oh, we did. And you're not going to like the story. It's in review right now. But the story is that we measured them again at 6 months and again at 12 months. Intervention stopped, right? If they were in the step activity monitoring groups, they got to keep their Fitbits, but no intervention. They declined significantly. The only group that was above baseline at the end of the intervention, at the end of the 12 months, was FAST plus SAM. So they did not decline back to baseline, but the other groups were back to essentially baseline on average. So the moral of the story is that we really, and that was incredibly disappointing to us because we were sort of taking the approach that we had taught them how to be more active in their everyday life. And that once we taught them that would become part of their habit. But we probably were being, there's been a lot of literature since we designed this study in the physical activity space that has shown that the behavioral interventions and the things you need to do to get someone to adopt a new behavior are different than the things that you need to teach them to do to retain that behavior. Some of them overlap and some of them don't. So right now, one of the things that we're thinking a lot about for our next study is how do we design an intervention that contains both the behavioral features that get them to acquire the behavior and retain it, because we missed the boat there. Does that make sense?
Yes, because that's what I expected from what I see in the patients. Maybe they need a longer time, or they might need to be more attached to the therapy at least even once or twice per month to be motivated.
So in a small study that we're doing right now where we're trying to implement this in the community with non-healthcare professionals, right? So we're just trying to implement this behavioral intervention with non-healthcare professionals who are just trained to do it. One of the things that we're going to be looking at the next iteration of that study is exactly what you're talking about. If we do 1 month checkup calls, just phone calls where we're checking in, we're asking them, we're probing them. Hey, have you been watching your Fitbit? Are you meeting your goals? We're trying to see if those little booster sessions are enough.
Yes.
Again, with the pragmatics in mind.
Yes. That's great.
Darcy, so my phone is capturing my steps. That's obviously not what you used.
Right.
So I was wondering, what do you think about monitoring? And, how will we ever get to the level of where it'll be something as simple as it's our phones that actually would be the not at least the easiest? Because I'm just trying to think about scalability.
Absolutely. So the reason we chose Fitbit is the price point, and it still is when you get a deal under $100, right? So, but that's still a massive barrier for a lot of people. Plus, you have to wear a device, and your phone. You pretty much at this point, people are carrying their phones around. The issue with the technology of the phone, and we've tested so many devices, and I keep testing devices every time new devices come out. You have to wear the Fitbit on the non-paretic leg ankle in order to get decent enough accuracy to use the Fitbit. And so there's these nice little, either people can strap it onto their shoelaces, or there's these little straps that they can put it in, make it kind of low profile so it doesn't look like you're like on the witness protection program or whatever, but you got to wear it on the ankle in order for the accuracy. So you're right, that's a barrier. The issue with the phones and stuff is they're not designed, the slow walking speed and the asymmetric gait, their algorithms just aren't designed to pick that up accurately. Where there's a will, there's a way, right? These companies have to be motivated to design their algorithms to be robust enough. And I've had conversations with Fitbit. They are, at this point, they do not see that the market is big enough. They are not really interested in investing anymore in improving their algorithms. We've talked a little bit with Apple because the Apple Watch is a nice option. Again, it's all for these folks. It's all about market, right? And unless they see that the market is big enough. So I think it's going to be incumbent upon people like you've got some great people, engineers working on some really creative stuff. I think it's going to be incumbent upon the medical professionals working with engineers to drive this. I just don't think the commercial markets are going to do it, right? Does that make sense?
Yeah. We'll tell our folks, who they are, to get working on this.
Well, you're working on much more sophisticated things than this, and eventually I think could be made even more simple just for tracking steps. Yeah.
This is great. Anybody else? I know what happens is that as we come to the end of the hour, our rehab colleagues, they need to go back to patient care. Just want to make sure nobody else didn't have a question.
Keep your eye out for high intensity interval training versus moderate intensity walking training in people with stroke. That's the next clinical trial that we're working on. Great.
Well, when that comes out, we'll be asking if we can have another journal club.
Couple more years. Yep. It's a big RCT. All right. I'm so grateful to everybody for being interested and taking their time to be here.
Thank you. Thank you, Darcy. Really enjoyed it a lot.
Take care.
Thank you.
Thanks.
Bye-bye.
Bye.